So hello and welcome back. Today I'm going to talk about imaging in the diagnosis of chronic pancreatitis. This video is meant as a follow-up to the case analysis that was discussed in the previous video in this series. That was part 3.1a. This is part 3.1b in an approach to vomiting and or abdominal pain. So as we've discussed previously, the overview of imaging findings in chronic pancreatitis, that is with the notable exclusion of autoimmune pancreatitis, can be divided into parenchymal and duct changes. On non-contrast imaging, I had used a mnemonic to recall the parenchymal changes as A, alterations in pancreatic signal intensity, B, below average size gland, that is loss of parenchymal volume, C for cyst formation within the pancreatic parenchyma, D for dystrophic calcification. We'd also seen that non-contrast imaging, irregular duct dilatation due to duct stenosis and intraductal stool formation were findings that were seen in chronic pancreatitis. Now, on contrast enhanced imaging, there was a notable enhancement abnormality within the parenchyma of the pancreas, and the otherwise in the duct there were no changes. So I'm going to elaborate on these changes and show you the actual radiological imaging and how to interpret them. So getting right into it, approach to vomiting and abdominal pain, part 3.1b. So we'll be covering the topics under the following headings. We'll talk about parenchymal alterations in chronic pancreatitis, and then which are apparent on non-contrast imaging, and then what is apparent on contrast enhanced imaging. Then we'll talk about duct alterations in chronic pancreatitis. So as I've just discussed, on non-contrast imaging, you may have alterations in pancreatic parenchymal signal intensity. You may have a below average size gland, that is loss of parenchymal volume. You may have cyst formation within the pancreatic parenchyma or dystrophic calcification. Similarly, on contrast enhanced imaging, you can have alterations in pancreatic parenchymal contrast enhancement patterns. This is due to parenchymal fibrosis. Next, coming to duct alterations, you can have irregular duct stenosis with upstream dilatation, and I noted that this is usually a short segment stenosis. Then you can have intraductal stone formation. So coming to the first part, that is parenchymal changes. Parenchymal changes that are apparent on non-contrast imaging have particular pathological correlates. So we need to understand what is happening at a cellular level or a tissue level in terms of pathophysiology, and that as we do with symptoms, we'll extrapolate to imaging findings. So the first change that might occur is in a replacement of the normal pancreatic glandular tissue with fibrosis. This is due to stellate cell activation, as we discussed in the part 3.3 of this series. So that results in altered parenchymal signal intensity or radio density, depending on whether you're doing MR or CT. These stellate cells then convert into myofibroblasts, and this was something that we had highlighted in contradistinction to autoimmune pancreatitis, particularly IgG4 related autoimmune pancreatitis, because these myofibroblasts subsequently contract, resulting in tissue contraction. So there is a below average size gland, that is there is parenchymal loss and atrophy. Then we have branch duct stenosis with upstream fluid retention and or fusion of smaller acini to form cysts. So these are small cystic areas within the pancreas, which could be just, as I discussed previously, due to obstruction of the opening of the ducts into the main pancreatic duct, or due to fusion of smaller acini. And finally, we can have dystrophic calcification. Specifically, this results in calcification within the parenchyma and stone formation. So coming to it one by one. First, we'll talk about altered parenchymal signal intensity or radio density. So, altered parenchymal radio density is most apparent on MR imaging. You see a decrease in T1 weighted imaging in intensity on T1 weighted imaging. So, I've highlighted that in blue. This is an axial T1 weighted spoiled gradient recalled echo image, which has been fat suppressed. So, in this, there is a subtle decrease in signal intensity of the pancreatic tail, which has been shown with the arrow, while the rest of the pancreas is a normal high signal intensity. Similarly, there is a increase in the T2 weighted signal intensity on T2 weighted images. So that I've highlighted with this red highlighter. This is an axial T2 weighted haste image, and what we find is that there is a subtle increase in signal intensity in the pancreatic tail with mild dilatation of the pancreatic duct. So this is clearly chronic pancreatitis. Parenchymal changes that are not that are apparent on non-contrast imaging. The next one is your below average size of gland. So that is visible on both MR and CT, but I've highlighted MR here. So axial T1 weighted against spoiled gradient recalled echo images which have been fat suppressed. So what we find is there is a diffuse reduction in the width of the pancreatic head, body and tail with irregular duct dilatation. So as we recall from our discussion on acute pancreatitis imaging, the width of a normal gland, the head is 30 millimeters, that is the minimum. In the tail it is 20 millimeters, and in the body it is 25 millimeters. So it is 30, 25, 20. Now, parenchymal changes, the next change that we will highlight is cystic areas within the pancreatic duct, within the pancreatic parenchyma. So, in the image on top, this is a coronal T2 weighted haste image. Since it's T2 weighted, fluid is getting showing a high signal. So, a dilated main pancreatic duct is visible. with multiple dilated side branches which have been marked with arrows. These are not true cysts. Okay, these are dilated branches. Again, this is the next image is a coronal T2 weighted thick slab fast spin echo, also called a rare image. Also, some manufacturers call it a turbo spin echo image. We'll get to the details of that later. So, there's mild dilatation of side branches of the pancreatic duct, again shown by the arrows, and the main pancreatic duct and the common bile duct have normal contours. So, the cysts that are near the main pancreatic duct here are in continuation are likely dilated side branches. However, this cyst is unlikely to be a dilated side branch, and this is a pseudocyst from a previous episode of pancreatitis. Yeah, so that's a multiseptated pseudocyst. Now coming to contrast enhanced imaging. So on contrast enhanced imaging, what happens is that because there is fibrosis in the parenchyma of the pancreas, there is a delay in contrast enhancement. So in the image on top, we have an axial T1 weighted spoiled gradient recalled echo image, which on contrast enhancement is showing in the arterial phase decreased enhancement, that is a diffuse reduction in the enhancement of the parenchyma of the pancreas. In the next image, this is a axial T1 weighted spoiled gradient recall image, which has been contrast enhanced and taken in the venous phase. So in this, we find that there is a diffuse delayed enhancement of the pancreas. So normally the pancreas enhances early and uniformly during the arterial phase and early venous phase, whereas this pancreas is enhancing late but relatively uniformly in the delayed phase. There is also notable duct dilatation, which will come to. So duct changes, the pathological correlate is that there can be stenosis of the sections of the pancreatic duct with irregularity of duct diameter with dilation of the upstream regions, sometimes forming cysts as we've seen. So replacement of normal pancreatic parenchyma by fibrosis results due to stellate cell activation and secondary conversion of stellate cells into myofibroblasts pulls the walls apart, causing irregular dilatation of the duct. So there is irregularity of duct wall. Now stasis of pancreatic secretions with decreased bicarb secondary the decreased backup results in secondary mineralization of the of secretions inside and stone formation within the duct. So we'll just see these changes. The first two changes are apparent on this image. There is a what I've highlighted with red is the pancreatic duct. So in this axial T1 weighted spoiled gradient recalled echo image, which has again been fat suppressed, there is diffuse reduction in the width of the pancreatic head, body, and tail, as we've seen previously. And the duct, instead of being a straight line like this, is showing significant irregularity and areas that are very stenotic and some areas that are extremely dilated. So maximum normal width of duct is in the head 35, in the body 2.5, and in the tail 1.5. Now coming to the last changes that we see, that is stasis resulting in ductular stones, so stones within the duct. So as you can see, the upper image is actually an axial CT abdomen, not an MR for once, taken in the portal venous phase. How do I know it is portal venous phase? Because again the contrast has reached the portal veins and it is starting to, it is, yeah, it has reached the portal veins. Okay, so that's very obvious. Now there is calcification within the pancreatic duct, which has been highlighted with the arrow. It is CT which is better at picking up calcification rather than MR. Now, the same patient's axial T1 weighted spoiled GRE images, which have been again fat suppressed, show a reduction in the pancreatic signal intensity, but they completely miss the calcified stone in the duct. So it's not at all visible, and therefore this is one point at which the MRI is not as sensitive as CT. Okay, so in this discussion, I've covered the following topics. We've talked about parenchymal alterations in chronic pancreatitis, which are apparent on non-contrast imaging. We've talked about alterations in parenchymal signal intensity, particularly on T1 and T2 weighted MR imaging. We've talked about a reduction in the size of the parenchyma of the gland. We talked about cyst formation within pancreatic parenchyma. We talked about dystrophic calcification. Then we went over to findings that are apparent on contrast enhanced imaging. This was alterations in pancreatic parenchymal contrast enhancement. So we found that there was delayed contrast enhancement. Then we talked about duct alterations in chronic pancreatitis, which included irregular duct stenosis with upstream dilatation and intraductal stone formation. So that brings me to the end of this screencast on imaging in chronic pancreatitis. In the next discussion, we'll do another case with NET, but that case will be slightly different from this present case with minor differences, and we'll see how that leads us to autoimmune pancreatitis. And then subsequently, we'll talk about imaging in autoimmune pancreatitis and histology in the diagnosis of autoimmune pancreatitis. So thank you for watching, and I'll see you next time.